Good morning, everyone. Welcome to our COVID-19 webinar series where we've been talking about the science and the stories around this pandemic. Thank you, Nicole, and all my colleagues for getting us set up here this Monday morning. I also want to recognize and thank our partners, Colorado School of Public Health, including Dr. John Samet, who've been really thoughtful colleagues all along the way in helping us put this series together. I also want to recognize that today is a very important holiday for our Jewish community. It is Yom Kippur, and while our Jewish friends cannot join today, I do wish them well. If you have missed any of our past recordings, or this is your first time joining us, welcome. We have recordings of all of our previous episodes, as well as written recaps. Just go to the Institute website, institute.dmns.org, and you can find all of that backlogged information. If you're joining us on Zoom today, we want you to ask your questions in the chat feature. This is going to be a full-on Q&A and conversation today, so feel free to start sending in your questions right away. We do our best to try to incorporate as many of those we can into the discussion, but we do not get to all your questions. So the chat feature right there where you've been letting us know where you've been watching from is where we'd encourage you to ask your questions. If you've joined us on Facebook Live this morning, hello over there. We also encourage you to ask questions on Facebook. You can use the comment feature to do that. And we've got eyes on all these platforms, so we do see all your questions and we love to read them even if we can't get to all of them. So we are about 6 months into this pandemic, and not just since the virus first came about, but really kind of since it's really upended a lot of people's lives and we've had shutdown and things have really changed. And so we thought we would spend today's episode talking about where we've come in the past 6 months with our collective knowledge and where do we go from here. So we're going to spend a little bit of time reflecting today on the field of public health, the speed at which research has been done, as well as the public trust in science. And then take that and think about, well, what does this mean for the road ahead? So I'm going to spend about 45 minutes with a really esteemed guest today, talking about some of these big picture lessons and some of that forward-thinking ideas about the state of our nation's healthcare. So this morning, I am pleased to be joined by Dr. Georges Benjamin. Dr. Georges Benjamin is known as one of the nation's most influential physician leaders. As executive director of the American Public Health Association since 2002, he is leading the association's push to make America the healthiest nation in one generation. Previously, he was the Secretary of Health in Maryland and also worked as the Chief of Emergency Medicine at the Walter Reed Army Medical Center. He is a graduate of the Illinois Institute of Technology and the University of Illinois University of Illinois College of Medicine, board certified in internal medicine, and a fellow of the American College of Physicians, a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, and an honorary fellow of the Royal Society of Public Health. Dr. Benjamin is extensively published and, as you can tell, very well accredited. He is a member of the National Academy of Medicine and also serves on the boards of many organizations, including Research America and the Reagan-Udall Foundation. I find this quite interesting. In 2008, 2014, and 2016, he was named one of the top 25 minority executives in healthcare by Modern Healthcare magazine. And in addition to being voted among the 100 most influential people in healthcare from 2007 to 2017. So we have a very established and high profile guest joining us today. And I am pleased to hopefully hear a lot of good information from him throughout the next 40 minutes. So good morning and welcome, Dr. Benjamin. How are you today?
Kristen, good morning. Thanks for having me.
Great. We're really excited to dive right in. And so this is going to be a straight up Q&A, like I said. So I actually want to start talking with you a little bit about public health in general. So something I realized we actually have never done, and I'm sure most of our audiences have a really good definition of this, but I would love if you could just talk to us a little bit about what is public health and what is its role in outbreak management.
Sure. So let me just say that, so I'm an ER doc. And I would love to think that my time in emergency medicine, I did health promotion, disease prevention, and I took care of sick people when they got injured or ill. But what public health does, it does health promotion, disease prevention, and disease control. But we do that on a population basis. So we do it by the fives, the tens, the millions, the hundreds of millions. So it's really done very much on a population basis. And we do that through 10 essential services. So I'm going to share my screen here. And I'm excited about this because this is a new, refreshed, just rolled out a couple weeks ago, 10 essential public health services. And for those of you, for those of you who don't recognize it or kind of recognize it, because it's similar to the last one, but we do everything we do in public health through assessment, by assessing the community, understanding what's going on, getting the data, monitoring population health, and investigating and diagnosing what's going on in the community. It might start with a single case, but as you know, there's often, just like with COVID-19, becomes large numbers of cases. And then we craft policy to address it. Policy programs, regulatory activities. We search for solutions by communicating effectively to inform and educate, by trying to mobilize communities, getting political support, getting community support to that. I'm gonna come back to that issue around politics in a moment. Creating champions to support the policies and procedures that we do. And we have regulatory authorities. And as you know, there's been a big debate in some communities about the public health regulatory authorities. We have enormous police powers to try to put in place health protections. We're very judicious in how we use those, but it's important to understand that public health can do some things to enforce the authorities that we have. And then assurance. You know, at the end of the day, if it asking that it gets done and having a policy that it gets done doesn't mean that it gets done unless you do some things that assure that they happen. To try to build a diverse workforce, because equity is at the center of everything we do in public health. Doing the research and quality improvement so we understand what we're doing. So public health does a fair amount of research. And build and maintain an infrastructure for public health. You know, by the way, that's in many ways that's failed us. Now, on the policy front, let me just remind folks that those of you who are very familiar with the very, very famous story of John Snow, who in order to, in 1800, in order to quell a cholera outbreak, before we really understood even the biological basis of disease, of infectious diseases, was able to convince the city leaders to take the pump handle off the pump where he thought people were getting contaminated water to drink. Now, he did not sneak off in the middle of the night with a wrench and take the handle off. He had to convince the city leaders to do that. And one of the more interesting things, he was able to do that in a very religious time by convincing one of the religious leaders to support his position. So in many ways, he did everything in these 10 essential services by assessing and understanding what was going on, the stick pins that we all remember from those of us who had public health school and public health classes. He thought about what he had to do from a policy perspective, i.e., he had to figure out how he got them to basically pass a referendum that you couldn't drink from the water. And then he actually made sure the pump handle came off. So just pointing out that politics does play a role in everything that we do because we do policy, but we do it through science and not because we're pushing politics, but because we're trying to push science as a way of getting things done. So with that, let me stop and just point out the final thing is that public health, we often say that our best work is done when nothing happens. And that's our goal. Our goal is to prevent things from happening in the first place or to mitigate them in such a way that you forget that they happened in the first place.
That's great. So let's build a little bit on that and just unpack that a little bit more about policy versus politics and the role of public health within that. And what often seems at times things that have become politicized. What, you know what I mean, as someone who works intimately in both of those spaces, what are some things that have become politicized that you don't think should have become politicized? And your role in helping to prevent some of that politicization?
Yeah, let me talk about two things. Let me talk about mass let me talk about the false choice between the economy and public health. And then we can eventually talk about vaccines, I'm sure. So masks, traditional wisdom was that the mask would not protect us, the broad public, in a droplet-like infection, which is the primary mode we think that COVID is past. At least that still is the prevailing view, even though aerosolization does play a role, and fomite transmission, meaning getting it from touching a surface that's infected, does play a role. And that's because your mask doesn't fit tightly around your face. I have my APHA mask, my APHA Speak for Health mask, and just remind folks that it's here, and it lifts up. I breathe around it, and we believe that those masks would not protect us as much. And so initially we told people that masks, we ought to save the masks. We're primarily talking about N95 masks, they're really tight masks that healthcare providers needed to use. We were trying to preserve those because we knew we didn't have enough, and we didn't think the paper masks or the cloth masks would be that effective. Turns out that a lot of study has been done since then, and it turns out the masks are highly effective for this disease in particular. And it got politicized early. It became a blue state, red state argument. It became a I believe in COVID versus I don't believe in COVID argument. It came out very early as you told us one thing and you told us something different. And that was just very, very poor risk communication. We started with what we thought we knew about mask wearing and this disease. We also did that in the context of not understanding the percent in which this disease was passed asymptomatically. So, if everyone who gives you the disease is symptomatic, then you can stay away from people that are symptomatic, and they can stay away from you. But it turns out as much as 40% of the people who can be infected can pass it along asymptomatically, or people who are infected pass it along asymptomatically. So that changes the ball game, and that makes the mask even more important. So that was the first one that got politicized. The second thing was this false dichotomy that the economy has to be preserved at all costs, and that health is not as important. Initially, health was very important, and the economy doesn't need to be preserved, but health is more important. We can have both, but the secret to preserving the economy is to protecting our health. And I remind people that health is 18% of the gross domestic product of this country. So we are already into the economics of the country by virtue of the fact that we have a big health system. And the best way for us to get out of this pandemic is to focus like a laser on the health stuff, and the economy will follow.
Let's go back to that kind of first point you were talking about a little bit with the communication. So information was coming out very rapidly, and I think people were expecting everyone to have the answer right at the beginning, of course, which we didn't. Not only did science unfold and is still unfolding in real time and very rapidly, information is coming out very rapidly. Information is changing. What are some ways that we could be doing this better as far as communicating in this at sometimes very uncertain space? Who has that authority? Where have you seen really good communication coming out? And what should our audience be looking to when they're trying to find answers in sometimes where there's not really solid answers?
Well, clearly in political leaders, the governor of Ohio and the mayor of New York have been two exemplars in terms of good communication, including his health secretary in Ohio. She was doing an incredible job of effectively communicating to the public. I think that in terms of health leaders, obviously, Tony Fauci is the gold standard in terms of telling us what he knows. In the old days, which was not too long ago, we used to have daily briefings in crises like this for infectious diseases from the CDC. And they would come up every day and they would say, look, this is what we know today. They would remind us each and every time that this is a new disease that we've not seen before. They would remind the public, because we forget, very, very quickly we forget these things. And yeah, we learned something new today, you know? And here's why we're changing what we told you. And here's why we're changing what we told you. So that people get a sense that we're not, you know, shooting from the hip, that we have a rational reason for doing something. Now, people may still have the right to disagree, you know, but they don't have the right to be disagreeable about it. And they should argue their perspectives. But that's what's not happening. CDC is putting a lot of really good science guidance on their website, but it's kind of being snuck on the website. It's kind of just being posted. Normally they would say, okay, here's what we think, and here's why we think it. And sometimes that public debate results in changing the guidance, and that's good. But unless you know why they were saying what they're saying, or having them to explain the intricacies of the details, because the devil is in the details of all this science stuff. And a lot of it is, yes, this is what we mean, unless we mean this, or unless this happens. And that's very, very important. And that's not happening right now.
Yeah, one of our guests was asking about the legitimacy of information, right, that gets put on these websites. Could you speak to the legitimacy of information coming out from, you know, HHS and other government agencies? And I'm assuming, you know what I mean, when we see our experts, when we see our leaders, when we see guidance coming out from institutions, you know what I mean? Those are the trusted sources that we need to during this pandemic. I wonder if you could speak to a little bit about people's questioning legitimacy.
Yeah, well, most of the information they put up there is pretty good information, but unless it's been messed with by people that don't know what they're talking about. And what's happening is there have been several very, very public meddlings in the information that's put up. The CDC has a very good process to vet information before it goes up. I mean, quite frankly, a lot of us often complain that it is sometimes too perfect, you know, and it sometimes takes too long, and they're often far too cautious when they put information up. But they have a process that they trust, and several eyes get on the information. Anyone who's ever written anything knows that when you've written a perfect essay and then you give it to someone else to read and they find all the mistakes that you made, knows what I'm talking about. You know, I just did that with a blog I wrote the other day. It was beautiful. It was masterfully written until the copy editors got their hands on it. And, you know, I have a tendency when I type to misspell the word health. I transpose the E, the A, and the L all the time. By the way, the spell checker doesn't catch that. You leave out words, you leave out verbs every now and then, pronouns every now and then, and sometimes you leave out whole lines of thought because you're typing, you're writing, and your brain is moving faster than your fingers. So yes, and then when you read it, of course, your brain picks up what you thought you said there. So I think that's a challenge. In having these kinds of things and not having a process. And what's happened is we've had people who have had motives other than the purity of informing the public in a science-based way, interfering in the process. And that's why we're beginning to lose trust in those institutions. Let me just say, we need to stand behind those institutions. We need to push back against these uninformed voices and actions, and support the folks that want to do this right, if we're really going to save lives and prevent disease.
I don't know if people could see me, but I was chuckling and nodding when you were talking about the brain writing things that you thought were actually coming out in black and white. Happens to me all the time. I'm like, I read it in my writing. Anyways, let's stay on topic here, but I'm sure many of us agree with you when it comes to that. So let's talk a little bit about kind of where we are, maybe like what has gone right and what has gone wrong. So let's start there and say, actually step back even further there. And what is one big thing that has surprised you since we kind of really have been tackling this for the past 6 months?
Yeah. So let me say that the science enterprise has gone generally well. I mean, the scientists behind the scenes that are working on the studies on vaccines, that even though we had the initial failure on the testing, there's been a lot of new, real interesting innovations that have happened that I think have been really kind of neat. I think the biggest thing that surprised me was not that I didn't know that disparities would be terrible and that they occur with every new disease, but these health inequities have been so profound. Even I was surprised at the degree of illness and injury that has occurred from COVID in communities of color. I was one of the early people that said, listen, we need to get our hands around this. This is back in the end of February, early March, right after this thing happened, when we saw some early reports coming out of China that people with chronic disease, if they got infected, got sicker. And that surprised me. I think the work of the medical care community, the learnings that we've learned about how to manage this disease, particularly in terms of airway and ventilator management, we've made profound understandings there and improvements in our clinical practice. We've also, the public health folks have been working like a dog. They have not gotten credit for the work that they have done around containing the disease by any means. And that certainly is very, very important. And I'm pleased that the work that they've done. But when your hands are tied and you're not getting the information that you need, and the technology you're left with to share information are fax machines in an environment where social media can share information or misinformation, and sometimes disinformation at the speed of an electron, and you're sharing information with fax machines, we got a problem.
Yeah. What about, okay, so stay with the disparities, inequities, and the disproportionate impacts on communities of color. What are some specific things that have been done to try to decrease these effects on the Black, Latino, and other communities of color that have been seeing disproportionate impacts? And are there differences in treatments being developed for them?
So we know the reasons for the higher numbers. Really three, and I shouldn't be surprised to anybody. The fact that many of these individuals are public facing, so I can telework from home. All the white collar workers that have computers can telework from home. That's great. But bus drivers, transportation workers, highly impacted. Meat plant workers, people who work in poultry farms, folks that are at grocery stores. Those folks are out and about. The people that pick up a trash every day, the essential workers, are much more likely to get exposed by a disease where you get it person to person. Secondly, a lot of delays in actually sheltering in place, even for those people that could shelter in place, because of the fact that early on there was lots of terrible rumors about the fact that African Americans, for example, were immune from this disease. That was going through social media, or misunderstandings of how you got the disease. Delays in testing. I think we all marveled when we did the drive-through testing sites. We knew we were short on tests, but remind yourself that when this initially happened, we were testing people based on whether they were sick or not. If you didn't have a car and you're not well, taking a train and a couple buses and then walking a few blocks to go get tested wasn't an option. And if you didn't have a car, sometimes getting a test was not an option. So that the structure of our early testing activities were desperate in their very nature. And we should have known better. Now, what has happened to try to fix some of that? Well, absolutely. there have been efforts to move testing into communities of color, into lower income communities. We've always known you have to open up the testing sites on weekends and after hours. We have to acknowledge people. Many of the people that are at highest risk are shift workers. And so we have to make it more available. So communities that have done that tend to have better access to testing than communities that haven't, now that testing has rolled out in a much more advanced way. I think there was a lot of work done by the healthcare community to figure out how to share resources. The downside is they shouldn't have had to do that. That should have been led much more assertively at the federal level. Buying equipment, we shouldn't have had states bidding against one another for equipment and supplies. They weren't designed to do that. We could have done that at the national level much more effectively than we did. I understand there was reluctance of the federal government to get in that space, but that was ill-conceived thinking, I believe, on the part of the federal government. And I think not having a unified voice, that's a real problem in part of this. Now, there are lots of tests out there, and like in any disaster response, they're never perfect, but we had a blueprint that was left for the new administration, which they did not follow. And then the lack of any real written plan. One of the reasons for planning is to field test, ideas. People get into a room and they throw ideas on a piece of paper and they talk about them and they fight over them, they argue over them, they trade ideas, and then they come out with a plan. And then they implement that plan, and the plan kind of works, but then they have to update it along the way. But a plan gives you a way and a blueprint so everybody can see themselves in it and know what their roles are. And that didn't happen in an effective way with this pandemic. And quite frankly, that's why we have over 7 million cases and over 200,000 people have died, because we really have not approached this with the thoughtful enterprise that it is, that it should have been.
Let's dig in a little bit to supplies, supply chain, supply lines that you were hinting at for testing, because I know this is going to come up to play when we talk about vaccines too. So where are some weaknesses that we currently have in supplies? It seems like testing is moving in that right direction, if not, really achieving what we need for right now. But where are we still struggling when it comes to supplies and being prepared for deployment of a vaccine?
Well, there are certainly things that the administration's done a little late, but better. Obviously, they're trying to ramp up testing. We're still we're near where we need to be, but they, they got on top of that and they began to push that out very differently than we did when we started up. I think that at the end of the day, we don't have to wait for a new administration, the next administration, to get started. I mean, we know what we have to do this. This is not rocket science. This is basic public health practice that we know works. And as we're thinking about this, we can turn the corner today and begin to do things in the manner that we know works. The science-based evidence, stop undermining science, put CDC out there in a lead, unbridle them, let them give us press conferences every day. Stop being afraid of what they're going to say in terms of the impact that it'll have on the economy of the stock market. The stock market is quite resilient. The stock market folds if somebody sneezes. You can never predict what the stock market's going to do. But the faster we get our hands around this epidemic, the faster we're going to be able to, return to as near normal a state as possible. We ought to talk about the fact that we're never going to be like it was a year ago.
So, what is your projection, right? You know what I mean? We are shifting into, quote unquote, a new normal, but there is no normal again. But, COVID, when do you think we're going to get our hands around to a place where, You know what I mean? Right now, there's still restrictions on shutdown at various level degrees, from the local to the state to other levels, right? So, I mean, in the next 6 months from now, the next 12 months from now, right, what does that start to look like for you, where people can start to feel like COVID isn't front and center to so much of their activities and day-to-day life? What does that look like?
Yeah, I do think that the vaccine is a game changer in terms of changing the way we approach this and function in our daily lives. Let me talk about what we need to do this fall. First, this fall, we have to recognize that we're about to get hit with the annual return of influenza. And so the good news is that wearing a mask, washing your hands, and keeping your distance is also a good strategy for influenza. And so many of the things that we're doing for COVID will help us reduce the impact of influenza. And in fact, that has been the experience of the Southern Hemisphere, where they had a relatively light influenza season, but only because they did all of those things, plus they had flu shots. So people should get their flu shot. It helps from a clinical perspective with a differential diagnosis. That does not mean that they still may not test you for flu and test you for COVID, but it's helpful not to have to deal with the symptoms that are similar with two diseases. Because if you had the flu shot, that means that you're much more likely to have something else. It may not be COVID, but you have something else that has an influenza-like disease presentation. And so that would help us deal with these two outbreaks that may continue in the fall with COVID and then be superimposed with influenza. Once we know we have a vaccine that's safe and effective, want to remind you that we've not done any studies in kids yet. So this is going to be an adult discussion for a while. Then we'll start giving people vaccinations in a prioritized way for COVID-19. And it'll be this time next year. We'll still be wearing masks, washing our hands, keeping our distance at some degree, and hopefully getting vaccinated. So next year's return to school and return to sports should be very different, but still measured next year. APHA, we're hoping to have our annual meeting. By the way, we're hoping to have our annual meeting there in Denver. And we know there's going to be a hybrid meeting. We know that we'll have people there. At least we're anticipating having people there face to face, but we also know that we'll have a virtual component to our meeting as well. And so we're going to be doing that. And we're going to, of course, encourage mask wearing and hand washing and physical distancing and all those kinds of things because, and by the way, we'll be really pushing people getting their flu shot before they come for that very reason.
So I had a great question here. This is going to be slightly out of right field, but I think it's a good question from one of our audience members that even though we've drawn from the WHO, the World Health Organization, how much are we still working with other countries on vaccines and other COVID-related things?
So it turns out that the scientists are ignoring the politicians and are still working behind the scenes together. We're still working with China. We're still working with the World Health Organization and other nations. There are still lots of conversations that are occurring around the world. Scientists are sharing their information through through journals, through a range of backdoor channels. And we're kind of just saying, ignoring the politicians, quite frankly, who I think are becoming, some of them, not all of them, but some of them are becoming obstructionists to this process and are eroding trust. But to the extent that we can continue to work with our colleagues around the world, scientists rock.
So this person specifically asked about vaccines, and we have a ton coming in about vaccines. We actually had Dr. Hotez on our last episode talking about vaccines and a little bit specific level. I'm sure you're familiar with him. But I want to ask you a little bit about vaccines too, because it is really front and center. I mean, I was reading about China this weekend pushing out a vaccine to a lot of people. And we know we're in phase 3 trials for a number of contenders here in the US, especially around the world as well too. So a couple things regarding vaccines. I'd love if you could talk to what is the emergency use authorization and how that might be used to deploy a vaccine, as well as what are some of your thoughts to a really well-planned and well-communicated vaccine program.
So the emergency use authorization allows you to use a medication, quote unquote, off-label before it has gone through the full process of the Food and Drug Administration's regulatory aspects. It means that they are in effect accepting the word of the pharmaceutical company that they have done all the right things to ensure that a drug is safe and effective. It's often used when the paperwork is going in and all of the I's have not been dotted and T's crossed around understanding all of the science around the regulatory process. All the committee meetings have not been held. I think the concern, of course, is that that will be used as a way of accelerating bringing the vaccine to use. And it may very well be that it's okay once we have enough data and the scientists have looked at the studies and say, yep, that data is okay. And so now we're going to expand the use of this vaccine to a broader group of people for purposes of getting the process started and getting some population protected. But the best way to do this is, of course, to finish all the vaccine trials and make sure that the trials have been done as designed and they're answering all the questions that at least initial designs of the studies were designed to answer. Safe and effective means that the vaccine elicits an immune response. And by the way, the early studies show that it does elicit an immune response. And then that the complications are the benefits dramatically outweigh the complications of vaccines, of any individual vaccine. A sore shoulder or a little bruising is generally viewed as not a serious problem. Something that causes severe neurological disease, either early or late in the process, will be a much more serious complication, as I'm sure Dr. Hotez pointed out. So what we're hoping is that the process as we go through, that EUA is not used as a way of undermining the research studies, but as a way of accelerating access to the vaccine that has been shown to be safe and effective.
Thank you for that. So we have an interesting question here that I think may kind of start to head us into wrapping up this conversation, because I would like to ask it and have you unpack it. So we had one of our guests who suggested that by looking at the stats and kind of the high number of infections we have in our country compared to other countries around the world, the high death rate we have, the high per capita death rate, it appears that we're maybe kind of in last place globally when it comes to our response in the pandemic. And so how would you rate our response so far? And I'm actually going to put a number scale on this between 1 to 10. How would you rate our response so far? And then depending on how you rate that, why? And then how do we get to a little bit of a, in the next stages of our response? How do we increase that to what I'm going to hope is like a higher response rate?
So let me just point out that prior to we were, as they looked at all the nations in the world, there were all the response systems were rated, and we were rated at the top. Now, by the way, all the systems were not rated really well. We all had problems, but we were rated at the top. And I think we have clearly shown that our performance is near the bottom. So on a scale of 1 to 10, we're somewhere around a 3. And how do we get to be 10? We get to be 10 by having a unified national voice, responding putting together a strategic plan, both to manage this outbreak, to do testing, to make sure we have equipment in place, follow that plan, remodel it as necessary, allow the scientists to and medical personnel to talk to the American people frankly, to provide the political leadership that this outbreak deserves in a way that does not undermine the science. And we're going to put more money on the table. I understand it's going to require more money. And then as we look forward, we're going to have to build a public health system that we can truly be proud of, that can identify anytime a new threat enters the community. So remember that we were all worried about COVID-19, but we just went through Zika and SARS-1 and Ebola. We had an opioid epidemic, by the way, has not gone away. It's gotten a little worse. An obesity epidemic, which has not gone away and has gotten a little worse. And the opioid and obesity epidemic resulted in almost 3 years of reductions in life expectancy in this country. So we have to make sure that we understand that this idea of having a public health system where our best work occurs, nothing happens, would be us getting to the 10. And knowing very quickly when a health threat enters the community by once and for all investing more of our resources and engagement in public health. Doing a better job of educating our political leaders so that they don't see the health department staff, that they treat them like they treat with respect their police chiefs and fire chiefs. When your chief of police comes and tells you something, most political leaders pay attention to it. When the fire chief comes and tells you something, they don't question their ability to manage the fire. But we're having far too many political leaders that are undermining and questioning the judgment of their public health folks. And I think that's unfortunate. And they're not, and I have to admit, some of them are not standing behind them when they go through these, they're getting all these threats from the public. When I speak to you, I'm speaking to you as your doctor, as your public health person. And if you're not a physician, great. If you're a public health person that's not a physician, great. You're speaking to them in your role as a good nurse, as a good person with a master's in public health, but you're doing it based on trying to protect their health, and you're not telling them this based on politics.
Well, let's have one final thought then on the public. I know scientific literacy, public engagement in general, and education is important to the association. So what more could we be doing to become a more literate public when it comes to some of the science?
Yeah, there's some studies have been done through Research America, whose board I sit, and the average American can't name a living scientist, nor say where science is done. Well, let me just tell you, science is done in your academic health centers, in your communities. It's done at your museums. It's done in your health departments. It's done in your doctor's office. And the scientists in your community are your neighbors that do that. They're the doctors and nurses, and they're the chemists, and they're the biologists that work every day asking these questions. So when someone asks you, who does science in your community, name one of those places. And if it's the museum, that's a great place to start. I grew up living in the Museum of Science and Industry in Chicago as a kid. I practically lived in that building. If you want to know who a scientist is, and you can't name at least one living scientist, please give the name Tony Fauci.
Thank you. And Dr. Georges Benjamin as well. So.
And my good friend Jonathan Salmon too.
Oh yeah, Dr. D. Yeah, yeah, everyone should hopefully have gotten to know his name who's tuned in so far. He's joined us at least, I think, for 3 now. So he's definitely been one of our local leaders here in the state of Colorado. And I'm extremely appreciative for him for introducing me to you and having you join us today. I am so thankful and grateful for your time and for your expertise and for sharing the past 45 minutes with us. So thank you, and thank you for all the work that you're doing.
Kristen, thank you, and thank you for having me with you today.
It's been great. Thank you to our audience today. You all had a wonderful set of questions. Hopefully we got a few of them addressed, but not all of them. Just a friendly reminder, we do have these recordings available as well as written recaps if you're not a person to sit and rewatch a whole video. On our Institute website, just go to institute.dvns.org. You can find today's once that comes up in about 24 to 48 hours, as well as all of our other previous recordings and written recaps. So as a reminder, we are now down to an every other week schedule with this series. So we're off next Monday, and then we'll be back on October 12th. And what we're going to do is we're actually going to build on today's conversation, and we're going to take it and bring it back a little bit locally and kind of have a little bit of a similar thing of talking about 6 months in, but where are we as a state of Colorado? So a little bit more here, focus on the state of Colorado, even though I know we have audiences from all over the US joining us. So that's what you can expect for October 12th, 8:30 a.m. Mountain Time on that Monday. Make sure you're on our mailing list, and I think Nicole's going to drop in all of our Twitter handles so you can follow us on social media if you will too. I hope you have a great rest of your week, and thank you for joining us.